Hello and welcome to today's webinar, Integrated Care Programs for Dually Eligible Individuals in the Era of COVID-19, Response Efforts and Policy Recommendations, made possible with support from Arnold Ventures. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question-and-answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. We'll now turn the webinar over to Michelle Herman-Soper, Vice President at the Center for Healthcare Strategies.
Thank you very much, Travis. Hello, everyone. My name is Michelle Herman-Soper, and I'm the Vice President of Integrated Care at the Center for Healthcare Strategies. I'm delighted to welcome you all today to today's webinar. And I also would like to thank Arnold Ventures for their generous support of this webinar and related project activities, as well as Spire Healthcare Strategies and Brianna Enslin for their partnership in this work. Just to start off with a quick overview of our organization, CHCS is a national nonprofit policy center that is dedicated to improving health for low-income Americans. We work with state and federal agencies, health plans, providers, and consumer groups to create programs that better serve beneficiaries of publicly financed care, particularly individuals with complex or high-cost needs. Spire Healthcare Strategies helps public and private sector clients navigate the rapidly changing healthcare landscape. A boutique consulting firm, they bring 3 decades of experience leading Medicaid programs across the country, developing state and federal health policy, and helping healthcare organizations respond to market and policy changes. Next slide, please. Can we advance the next slide, please? Thank you. And actually, oh, that's perfect. One more. Today, because of our fantastic lineup of speakers, actually one more forward to the speaker slide, please. I thought I would run through the agenda at the same time I introduce everybody. So after I provide a brief introduction, I'll turn it over to Ariel Muir, who is the Vice President of Healthcare or Complex Care at Arnold Ventures. Then Tom Betlach, a partner at Spire, will review the policy recommendations that we developed in responses to COVID-19 in programs for dually eligible individuals. Then Michelle Bensington-Purrington, the Vice President of MLTSS at Molina Healthcare, will describe Molina's efforts to support duals in facilities amid COVID-19. Then Laura Chase, the Vice President of LTSS and MMP at Centene, we'll talk about Centene's approach to supporting people in the community during the pandemic. Last but not least, we'll have 2 officials from Minnesota's Department of Human Services, Sue Kavenju and Gretchen Olby, offer reactions to these efforts as a leading state, thank you for the next slide, dedicated to improving integration for dually eligible individuals. We'll wrap this up with a health plan and state roundtable, and then have the last few minutes for question and answer. Next slide, please. So I wanted to set the stage for this webinar by providing some background information on the people that we are focusing on, as well as the healthcare programs in which they are enrolled. People who are dually eligible for Medicare and Medicaid need to navigate, in general, typically 2 uncoordinated systems of care with different incentives, benefits, provider networks, and enrollment processes. This can be really challenging for populations with diverse but usually significant medical, behavioral health, functional, and social needs. And on this slide, you can see some great diversity and examples of subpopulations who all have significant healthcare needs or other related needs. This population has a high rate of multiple chronic conditions, as well as high rates of behavioral health and LTSS use. Their care accounts for a disproportionate amount of both Medicare and Medicaid spending for each program. These individuals are also often at greater, are often more likely to have significant social support needs, and there's a heightened risk of some of these needs related to social isolation, food insecurity, and behavioral health needs during COVID-19. And then lastly, the current fractured system design has really been exacerbated, and it shows in the data that CMS has been collecting since the COVID pandemic began. Dually eligible individuals experienced a 4.5 times higher hospitalization rate compared to beneficiaries with Medicare only. Next slide, please. There are more than 10 million individuals fully eligible for both Medicare and Medicaid who are served by a patchwork of different programs. As of 2019, only 1 million of those individuals were enrolled in an integrated program that combined their services. And this map highlights the states that have made the most advancement and developed the most innovative programs to actually integrate the two programs for these individuals. This shows primarily two programs. One is financial alignment initiative demonstrations, in which states partner with CMS to test models in a capitated or managed fee-for-service design that aligns Medicare and Medicaid financing and delivery. In addition, many states excuse me, have developed fully or partly integrated Medicare Advantage dual eligible special needs plans with strong linkages to Medicare, Medicaid managed care plans that require or encourage individuals to enroll in the same plan for both sets of services. Next slide, please. Then I'll just conclude by telling you a little bit about the work that we did. During the summer of 2020, CHCS Inspire conducted research on current response efforts within programs for dually eligible individuals. Based on the information collected, we developed a series of policy and programmatic recommendations for policymakers' consideration. We produced a report that will be available next month that outlines some key response efforts excuse me, undertaken by state Medicaid agencies and integrated health plans, as well as the policy recommendations I just mentioned, and she'll hear a little bit about more today. And again, today we'll talk through some of the highlights of that work. And before we do that, I'm happy to turn it over to Ariel to share some key priorities for Arnold Ventures in the complex care space during this challenging time. Thank you.
Thank you, Michelle. And thank you all of you for joining today. Many of you may be familiar with Arnold Ventures and our approach to philanthropy, but our investments in the complex care space are relatively new. So I thought I'd take just a moment to share a little bit of our mission and why we care deeply about using policy to mend the broken system affecting the vast majority of people who are dual eligible. AV's healthcare work is motivated by a deep concern about the affordability of healthcare for individuals, for governments and employers. One focus of ours are the high prices that we pay. You may be familiar with AV's work to try to lower drug prices and address surprise billing. We're also drawn to populations and services that represent a disproportionate shares of spending and where outcomes are poor. Next slide, please. A prime example of that is the fragmented and uncoordinated systems of coverage and care for people who are dually eligible for Medicare and Medicaid. As Michelle said, at AV, we're investing in policy analysis and policy development, research and technical assistance to advance the integration of Medicare and Medicaid for this population, to increase enrollment in integrated delivery systems, and to ensure that integrated programs can and do deliver the mix of services to meet the needs of their members. AV began our complex care investment strategy just over a year ago, and despite the important work that many people, even on this very webinar, have been doing for decades, it was rare to see this issue in the headlines. Since that time, and since the onset of the pandemic, it felt like the world has kind of turned upside down, and now the problems that have been long documented and warned of are routinely on the front page. The last 6 months have been replete with really devastating tales of loss and suffering. And while many of the issues we are facing still today are directly tied to this pandemic, like the need for adequate personal protective equipment, it's also really laid bare the systemic issues that people who are dual eligible deal with even in the best of times. For example, people have to navigate multiple insurance companies and uncoordinated providers, which is worse when you have high medical needs. And our social safety net is oftentimes disconnected from health to address things like social isolation or food insecurities, which have been particularly acute during this time. These are the things that matter to people and they associate with health and well-being. These are things that are important to people and they see as part of their health and welfare. So the conversation we have in store today, it motivates me both with urgency as well as stamina. Many of the recommendations that Tom will share and will be discussed can be acted on today, and that makes me hopeful. It is also my hope that attention to this crisis will motivate all stakeholders, state agencies, CMS, plans, providers, other philanthropies, to move to the next step and the next one after that until we have a system of care that is seamless, that is person-centered, and that is oriented towards value. So thank you again to CHCS, to Spire, to Bree, and to all of our panelists for participating today. Look forward to the discussion, and I will pass the mic over to Tom Bettler.
Well, hello, everybody. It's great to be with everyone today, and special shout out and thanks to Ariel and the team at Arnold Ventures for their support for this project and complex care populations and all their work around duals. Really enjoyed our partnership with CHCS after so many years of being able to really take advantage of all the great programs that CHCS has and offers to state officials. From that perspective, being able to participate with them in this project has been great. Thanks as well to Brianna Enslin for her work on this project and all of our panelists and all of the interviewees that we were able to engage with over the last couple of months. It's been wonderful to be able to hear about not only all the challenges that are being faced on the ground, but really some of the creative solutions that both states and managed care organizations are putting forward to deal with this pandemic, and particularly through the lens of trying to improve outcomes and services for dual eligible members. So I was the Medicaid director in the state of Arizona for 10 years, focused on this population, started my initial work as it relates on duals over 18 years ago. First project was to do Medicare Part D implementation, and it struck me then in terms of the fragmentation that exists in terms of serving dual eligible members and the silos that have been created as a result of it. You know, I feel bolstered by some of the progress that's been made, particularly over the last 8 years or so as it relates to the creation of the Office of the Duals and the demonstrations and the work around DSNPs and alignment efforts and some of those early results and what they've shown and how positive they've been. But I think what's really played out in terms of the pandemic is that we have so much further to go. So next slide, please. And I think that we heard this from one of our plan partners, and that was this quote, which I think really says so much in terms of the power of alignment and integration versus, you know, lack of coordination. So with Medicaid alignment, we have a single care management team that is agnostic about who pays for what, supporting a member-centric approach. We figure out what a member needs and then pay for it without involving them. Our experience has been that the model of alignment actually works. The unfortunate thing that we all recognize is that this is the exception and not the rule, right? This is the vast majority of the population continues to sit in an unaligned system, experiences fragmentation, and we saw how that play out. And so I'll echo Ariel's comments that certainly what would be great to see is that policymakers, both at the federal and state level, and healthcare leaders look at ways to improve services for the dual eligible population through the lens of the pandemic, and what can we really be doing to take the next step forward. Because while we've made some progress, and it's been important progress, we can and must do better. Next slide, please. So I think we all recognize on the left-hand side of your screen the challenges of dual eligible members and fragmented care. There's lack of financial alignment, there's uncoordinated care, and when you can actually integrate or align care models, you can really turn that on its head, and you can build financial alignment, and you can develop coordinated care, and you can really align incentives. But again, it's the exception and not the rule in terms of where we're at. And so Michelle described the process that we went through in engaging state leaders as well as managed care organizations and wanting to hear from them both in terms of the challenges that they're facing now during COVID, and part of the creative solutions that are being put in place to drive really some policy recommendations as it relates to try and improve outcomes for the dual eligible population. And many of these are going to look familiar to you all on this webinar, right? In terms of the challenges being faced. And that is caregiver support in terms of when you have a population that is locked down, that is frail, that is at risk, being able to deliver supports appropriately has been a huge challenge for nursing facilities and other institutions in terms of higher costs of care. In-home care, being able to go in, so many of the dual eligible members that we serve are in home and community-based services, being able to get into the home and offer those services. Maintaining necessary services around prescription drugs and chronic disease management. Member and family communications, and I'll add to that provider communications as well, have been such a challenge. I mean, if you just look back to March, which I know for many of us seems like years ago, just thinking through the various communication strategies. Some things have worked, some have not. But members, families, providers, they are looking to the state and the managed care organizations to be aligned in terms of what's being communicated. And that's been a challenge. Transitions of care have been an enormous challenge throughout this process. And we recognize that for individuals who may be in a setting, have to go into an inpatient setting because of testing COVID positive, and then that transition back out to the community, amplified by the fact that that individual is a dual eligible member and is in a fragmented system in which Medicare has now taken over in terms of the inpatient stay, but then looking to do that transition plan back out into the community that oftentimes involves so many important Medicaid services and the lack of coordination around that. We've seen key challenges in the service area. So it's already been mentioned and everybody's well aware of the challenges around PPE and testing. Behavioral health issues have actually seen the double impact of increased anxiety and depression, while at the same point in time seeing reduced utilization of services and having to see that group of providers really significantly shift to telehealth in a very quick fashion. Meals, I mean, if you just think about what used to be a relatively simple step of being able to get meals delivered, be able to go into a grocery store. I mean, if you think back to March and where we were in April and May, oftentimes there were not groceries available. Oftentimes we're talking about a population that being at risk cannot go into a grocery store. And so being able to get meals out to individuals. Social isolation, transportation, again, very significant challenges that states and plans and providers are dealing with in terms of being able to serve dual eligible members. Next slide, please. So the good news was that, as we were talking with state policy leaders and as we were talking with plans, there were clearly some areas where they were identifying potential solutions to many of those challenges. And so we're going to spend the rest of the time in this part of the webinar just highlighting some of those policy recommendations as ways to both, from a near-term perspective and a longer-term perspective, look at the ability to improve service delivery and outcomes for dual eligible members. So increased alignment, we've touched on that already, the importance of that, the importance of system design and being able to look at ways to better serve dual eligible members. Increased plan flexibilities to address member needs in terms of what states are considering and engaging with the managed care organization partners. Family caregivers and the importance of family caregivers and looking at flexibility around that. Developing robust communication strategies, again, focused on the member, the family, providers, and other stakeholders as it relates to alignment and recognizing that we still have a long way to go in this pandemic, and that we need to be thinking about strategies as it relates to the vaccine and other important areas for dual eligible members. Enhanced data sharing platforms. This was a reoccurring theme as it related to our conversations with states and with managed care organizations. And it really fell on the continuum of where we saw examples of fully functioning health information exchanges that were providing real-time information on individuals who might be testing positive, to sort of cobblestone together arrangements where individuals at a hospital that are case managers have built the relationship with the hospital case manager and were able to get information in terms of what's going on for individuals who might be testing positive. Ensuring fiduciary responsibilities. There's been a lot of discussions, and when you think about managed care and the per capita rate setting process, and you think about the significant decrease we saw in overall in a lot of utilization, and layered on top of that then higher costs for particular providers, I think there's a lot of great indications out there in terms of what states have been doing very proactively to manage their fiduciary responsibility and thinking about this going forward, and then thinking about how it has multiple year impacts in terms of how rate setting works and how to think about resources for providers. Reporting on utilization and trends is really just a piece of that as well. So if you're a fee-for-service state, you may be getting your claims data on a regular basis and evaluating what's going on there. If you're thinking about it from a managed care state perspective, there's a lag in encounters. So is there data you're able to get from your managed care partners more quickly? Now think about it from the dual eligible perspective, where as a state, oftentimes you don't have any insight into the Medicare piece of this. And so having some strategies around all of that and leveraging things like DSNP agreements and other types of ways to be able to get more real-time information, to have better insight in terms of what's going on with dual eligible members. And then services and thinking about expanded supplemental benefit offerings. And we'll talk more about that in just a minute. Next slide, please. So on the alignment between Medicare and Medicaid, and again, really looking at this from a system design perspective, and these first set of recommendations we called structural, just to look at different ways to improve system design and system delivery and service delivery. So in terms of thinking about this from the agreements that are signed by states, right? The state Medicaid agency contracts, the SMAC agreements, formerly known as the MIPA agreements as well. So each state has to sign an agreement with DSNPs that are operating, thinking about how to make those agreements have more teeth as it relates to care coordination and alignment. I already see some states talking about taking this opportunity to be thinking about ways and develop strategies to better build alignment, recognizing that that's part of the solution here in dealing with the fragmentation. And so how do you leverage regulatory aspects like default enrollment that allows the individual to be enrolled in the same plan for Medicare and Medicaid with the opportunity to opt out as they're becoming a dual eligible. And the Office of the Duals is open for business. They're looking for states to come forward creatively. And it's not just on a managed care chassis in which demonstrations can be done. I think Washington has proven successfully in terms of how to look at a fee-for-service type of demonstration to have better coordination and better serve dual eligible members. So those are some strategies I think states need to be looking at. But in addition to that, obviously we have to have a broader conversation from a policy perspective about what's the best system design to serve dual eligible members. And then there's the marketing aspect of this, in which managed care organizations may be able to reach out and better communicate in terms of what the opportunities are around alignment. We've seen significant changes in terms of how services are being delivered through the use of telehealth, through the use of remote visits, and that's going to be with us going forward. It's part of the transformation that we've seen occur throughout the pandemic, and managed care organizations, and states need to be thinking about what are some unique aspects about dual eligible members to be able to take advantage of some of the positive things around telehealth for populations that might not necessarily be as comfortable as other populations in terms of engaging around that platform and thinking about the opportunities that sit there. And then there's also, looking at relaxing certain regulations in terms of face-to-face visits and continuing to be able to leverage remote. You can't necessarily replace for a case manager being able to go in and meet with a member one-on-one and see their surroundings, but there are ways to leverage technology to be able to do that in the most complete fashion now that's available to us, given all of the circumstances. Next slide, please. We know workforce issues are significant in terms of who is available to provide services to dual eligible members. And so state Medicaid agencies, they want to think about what flexibilities exist. So family members, we know are an important part of caregivers. We've seen some states pursue flexibilities to be able to do more to support family caregivers. For example, Arizona has an 1115 waiver that allows it to pay for certain services for parents with kids that are individuals with developmental disabilities. So being able to look at ways to leverage broader workforce strategies. And then also we'll hear specifically from one of our plans that we were able to interview and is on the webinar today to talk about some of their creative solutions as it relates to workforce. Next slide, please. Around operational recommendations, let's talk a little bit more about communications, because it's been something that states and managed care organizations have been managing through in this incredibly fluid situation. But as I think about it, we are nearing a point of COVID exhaustion for many folks. They're looking for trusted sources in these very challenging times. We have issues around the vaccine and how information will be communicated out on that. And then we've got the challenges of what's going to play out in the many months as it relates to the winter season and flu. And so states and managed care organizations, they need to be looking at ways to have an aligned, enhanced communication strategy that really looks at this continued evolving space going forward. Enhanced data sharing platforms. So again, part of the policy recommendations we're looking at is ways to enhance and strengthen your contracts for states, and thinking about managed care and thinking about your DSNP arrangements and your contracts there to be able to get more information in a real-time basis. Also health plans, looking to continue to build ways, if you don't have, say, that robust HIE that discussed earlier, to build some incremental success around data sharing within the system. Next slide, please. So I touched on this earlier, and the National Association of Medicaid Directors came out with a blog last week, and it identified in a state survey that over 80% of the states have some form of risk corridor to protect the states as it relates to potential dramatic downturns in overall utilization. A risk corridor limits overall managed care profitability, and there's different ways to structure that. But in that data that NAMD published, they also identified that 43% of the states that are reporting risk corridors are actually new risk corridors. So these are states that are responding. We've also seen states use regulatory authority to establish directed payments. So they may say, I believe we have some resources available within the capitation. We're going to direct additional payments to, say, for example, nursing facilities to help cover their higher costs. So we've seen very active state roles from a financial regulatory perspective to recognize significant changes in utilization and also to deal with higher costs that are going on in the system. I think there's also a real opportunity here for states to partner with health plans to get some real-time information in terms of overall network stability. So just being able to see what's going on, and oftentimes with some very unique types of providers that really are unique to dual eligible members and unique to Medicaid oftentimes. So I'm thinking of like assertive community treatment teams for individuals with serious mental illness and other things like that. Also, I mentioned this earlier, but regular reporting on utilization and trends, being able to see what's going on in a more real-time basis, I think that's going to be important in terms of really recognizing what's going on in the overall delivery system. Next slide, please. And then finally, investing in supplemental benefits. And so there is quite a bit of new flexibility for the ability for dual special needs plans to offer some supplemental benefits through the Chronic Care Act of 2018. And even despite this added flexibility, we've seen roughly only about 10% of SNPs offering this enhanced supplemental benefit. We heard from managed care organizations about the opportunities associated with being able to offer meals and other types of supplemental benefits that are part of this. So again, I think there's opportunities for states to thinking about how do you leverage that contract that you have with the DSNPs to have more expectations around some of those supplemental benefits, and as health plans thinking about how best to position some of those supplemental benefits to better serve dual eligible members going forward. So with that and that series of recommendations, I am going to turn it over to Michelle to hear more about what some of the plans have been doing in terms of the pandemic and serving dual eligible members. Michelle?
Thank you so much, Tom, and special thanks again to Spire Healthcare Strategies, Center for Healthcare Strategies, and Arnold Ventures for shining a light on this very important topic and bringing stakeholders together to not only share best practices, but inform real-time structural and policy opportunities. I'm going to speak today about nursing facilities. If we could go to the next slide, please. Thank you. Nursing facility residents and staff have been really hard hit by COVID. Recent data from CMS shows more than 223,000 confirmed cases and 54,000 deaths amongst nursing facility residents nationwide. It's important to understand that Melina's experience includes that our nursing facility resident members, over 92% of them are dually eligible. So when we talk about how COVID has hit nursing facilities, we are talking about it really adversely impacting the dual eligible populations. It's important to make note that about 5-6 years ago, through participation in 6 of the Medicare Medicaid financial alignment demonstrations offered through CMS that provides integrated care for coordinating care for both Medicare and Medicaid services through a single payer solution, we were able to leverage a new pay for quality program, value-based program with nursing facilities. In this program, our nursing facilities have the opportunity to earn quality bonuses, monetary bonuses, services, paying for performance. And we have found these participating facilities serving our integrated dually eligible members have not only exceeded quality expectations, but have also reduced overall healthcare costs. The reason this is important is that a very important program and policy opportunity enabled this pay for quality program and also was a foundation for us when the pandemic hit. What we did is immediately mobilized with our nursing facility partners. And first I'm going to talk about the individuals whose lives we affect every day. So when we started the pandemic back earlier this year, the number one issues that our resident members, the individuals we serve, were facing was increased risk of socialization, or social isolation rather, fear and depression. This became an absolute concern and challenge for their healthcare outcomes and well-being. Also, limitations on the visitation affected our staff that go into the nursing facilities and help facilitate improvements in care, functional performance, and transitions back to the community. So what did we do about this? Talking with our nursing facility partners, our state partners, our community-based organizations, we did multiple things. The first thing we did is targeted communication. We solved barriers to enabling loved ones and friends to interact with the individuals in nursing facilities. We provided information to alleviate fear and share best practices of how people could protect themselves from the virus. These things were very important in combating that fear and social isolation. Some of the key barriers to communication are cell phone minutes. Many of the nursing facility residents and their loved ones have issues with obtaining cell phones, devices, iPads, computers, and then they also have barriers to being able to afford the data and cell phone minutes in order to communicate with loved ones. So we were able to teach people about applications where they could use Wi-Fi at no cost to their minutes, their cell phone minutes, or their data usage to engage with their resident nursing facility members. Now, these were big steps in combating some of that social isolation. We also used the same technology to enable our own staff members to get inside the nursing facilities again. As Tom mentioned, being able to have a care manager in the facility, interacting, engaging, monitoring progress, making sure an individual's needs are met, their care is coordinated, supporting our nursing facility partners with transitions back to the communities. These things are key. And we talk about telemedicine and telehealth. We're using the term televisit. And it's a very, very important part of facilitating transitions, keeping people safe in the settings of their choice. The other thing is care packages. So as we're informing and teaching people about the importance of face coverings, as we're talking about continuing to take care of yourself, nutritional meals and snacks, as nursing facility partners have staff shortages, it becomes difficult for some of these individuals to get a snack when they want it. So we started shipping care packages, nutritional snacks to our nursing facilities that enabled their residents to have their snack when they wanted, safely and securely. This also alleviated some of the staff burden that nursing facilities were facing. Finally, transitions. We started receiving an increase in family members and friends who were interested in transitioning loved ones back to the community. Some people had a change in working condition where they had jobs that prevented them from caring for their loved ones in a home-based settings due to loss of employment. That was now an option for them. So through accessing electronic health records to better coordinate with nursing facility staff members, community-based partners and family members, and that televisit technology, we were able to facilitate even more transitions back to the community during time of COVID. And in lieu of services in states where that's permitted, enabled us to wrap supports around members that needed some additional help at home. If we could go to the next slide. I'd like to shift gears now. Next slide, please. Thank you. I'd like to shift gears and talk about how our nursing facilities were affected. The first thing we heard about was increased costs. All of a sudden, there was additional PPE needed to keep staff and residents safe. Tests. These increased costs with no additional funding was a severe issue for our nursing facility partners. The other thing is access to PPE and testing. There was a shortage. I think we all personally experienced this, and our nursing facility partners certainly did. Staff burnout. That's something that nursing facilities often try and address on a daily basis. The pandemic only compounded that issue. And then staff members becoming ill as well resulted in staff shortages. So some of the things the industry did to combat this, and Melina specifically, is one, we expedited supplemental payments. As soon as state and federal governments released funds and provided the opportunity for supplemental payments, we expedited those. Additionally, we did so oftentimes in advance of that funding being released to the managed care organizations. Second thing we did is we leveraged our suppliers for PPE and tests, and we bought and supplied N95s, tests, face masks for residents, and we expedited getting those out to people. Additionally, those care packages I mentioned earlier, we included sanitizer. How many of people in the industry shifted from production of alcohol to hand sanitizer to help all of us during the pandemic? Well, we capitalized on finding folks that could provide those materials. We provided them again, not only for staff, but for the residents. The other thing is the staff burnout issue. Simple things for recognition. Providing nutritious lunches that could be dropped in no contact deliveries, yard signs of appreciation. These are just seemingly small things, but these are things that we could do to lift the spirits. And then finally, I mentioned direct access to the electronic health records. This was another way that we could directly get what we needed to help coordinate care and facilitate better outcomes and lessen the burden to staff. So facilities that didn't already allow us direct access into their electronic health record systems, many of them opened up that opportunity and we took advantage of it. So these are just a few of the ways that during this pandemic, we've worked with nursing facilities to improve healthcare and outcomes. I should touch upon one other thing. There is a state, one of the states that had a task force and enabled, actually a couple of states did this, and enabled healthcare professionals to volunteer to also help relieve the burden at hospitals and nursing facilities. We were proud to have several of our Molina clinical experts join those task force, help facilitate testing. So I just want to close with this. What are the policies that enabled some of these just heroic activities in our system? First of all, the demonstrations. The Duals demonstration initiative laid a foundation for improved integrated care, and the things that we have built, we capitalized and leveraged during this pandemic. Additionally, increased funding from both federal and state government partners, increased flexibilities in benefits offered, and offering in lieu of services. Where we were able to pull these levers, we were able to really address the barriers and take action to address the problems that were being faced. Finally, I want to just recognize a couple of recent activities. Yesterday, CMS announced $165 million of funds being released to states through the Money Follows the Person program to help increase transitions from facilities into the community in various ways. And it's just a example of the continuing evolution that we need to take advantage of during this pandemic and beyond the public emergency. And last week, CMMI announced another innovation model for direct contracting to better serve dually eligible individuals. Our state and federal partners have just really adapted quickly during this time of the pandemic. And if anything can come from this, we should all continue to be adaptable. So with that, I'm going to turn it over to our next presenter. Thank you.
Thank you, Michelle. So hi, I am Laura Chase. I'm Vice President of Long-Term Services and Supports, as well as our dual demonstration programs at Centene. And I'm going to be talking about some of the ways that Centene has been supporting dually eligible individuals who are in the community. And before I jump in, I do want to also express my appreciation for being able to participate in this discussion today. So thank you very much. Next slide, please. So one of our biggest focus areas from the beginning of this crisis was to make sure that our members who receive home and community-based services had no gaps in their essential supports. Our care coordination teams were very concerned about attendance and beneficiaries exposing one another, about how to quickly substitute different services as day centers were closing down, and about family caregivers not being able to provide support for a variety of reasons. We worried that the pandemic would make some of the longstanding problems around workforce and timely access to services even worse in certain regions. One of the first areas of focus we had was access to PPE. As you know, obviously PPE was a national challenge, and so you can imagine that if hospitals were having difficulty obtaining masks and gloves and the equipment that they needed, then our Medicaid attendant care agencies and certainly our self-directed workers were having an even more difficult time being able to order these items. So we did set aside some direct funding to purchase masks and gloves for members in several of our states who were self-directing their care, and also for some of our attendant agencies. And we even had some local volunteers. So our Pennsylvania Health and Wellness team had folks volunteering on the weekends to sew masks, which is great and actually turned out to be a great way to kind of engage staff and build some new relationships within that team. And then we worked closely with local centers for independent living to figure out safe ways and creative ways to actually deliver the masks to consumers who are self-directing services. Next, I want to talk about connecttocarejobs.com. So we had heard about the need to match workers with openings, especially as the virus started to ebb and flow in different states. So our IT team supported advancing states to build out this website, connecttocarejobs.com, so that states could help healthcare facilities and also home health and personal attendant agencies identify available workers. This is one where the intent is really to create something not just for the pandemic, but also for the longer term. So the site right now is currently live in several states, such as Washington, Oregon, Colorado, and Michigan. And we've got several more states on the horizon. Earlier, I had mentioned day centers closing. So as the pandemic began, our care coordinators quickly called thousands of our members to discuss alternate services that were needed, particularly personal attendant services and home delivered meals. More broadly, our care coordinators reached out to all of our members receiving home and community-based services to talk about their backup plans and make sure that they had a current plan in place if their scheduled attendant did not arrive or their meals were not delivered as expected. One of the scenarios we thought about, what if Plan B also failed? For example, what if the member were to contract the virus and their attendant and family members also contracted the virus or needed to self-quarantine? Who would be willing to go into that individual's home to assist them with their essential activities of daily living? So we worked with the National Council on Independent Living, NICL, the Association of Programs for Rural Independent Living, APRIL, and local centers in Pennsylvania and Kansas to begin a pilot for an emergency direct care worker program, which would build an infrastructure to be able to dispatch workers on short notice. The program just launched in the last 6 to 8 weeks, so unfortunately I don't have any results or data to share just yet, but this is another case where I think the pandemic has created a certain situation that has spurred some innovation, and this gives us an opportunity to learn about the demand for such a service, and if it is needed, then to build that infrastructure that could potentially last longer term. And then there was some discussion before around the workforce crisis and how in some ways non-traditional partners have been identified. So we actually did convene a group of LTSS stakeholders, provider organizations, states, plans, and then did invite some more non-traditional partners, so unions and looking at hotel workers. We got engaged with an occupational therapy students organization, workforce development boards, really to try to help build awareness of opportunities to serve older adults and people with disabilities. That is a career option I think some people, of course, didn't know very much about or hadn't considered, and to see where there were opportunities in industries that were hard hit to recruit workers to the extent that we may have a workforce shortage. So these are certainly relationships that that we hope will continue and will last. I will say also there were some immediate connections made around identifying sources for PPE, around signing on to different types of advocacy initiatives that were kind of common interest. And so it has been a great way to open some new doors there. Next slide, please. All right. So in addition to focusing on a continuation of services, we also have several other initiatives in place which support our dually eligible members in the community. One is that we put aside a fund specifically for CBOs, primarily AAAs and SILs, to respond to local needs around social determinants of health. And so we identified local organizations in 10 states where we thought the needs were most critical, and asked them to give us a one-pager, basically letting us know what the local need was if they were to receive some type of grant funding. And so we got some really creative and interesting responses. So one example is we heard, of an organization who had funding for masks, but what they really need is to be able to provide rent and utility assistance. We also got a request to start a tablet lending library and buy sterilization equipment for the tablets so that people could participate in virtual support groups, and also do a training fund for volunteers to become support group leaders in a virtual setting. So that's been a really great initiative that I think has impacted folks in various communities and leveraged the local infrastructure. We also continue to develop educational resources for beneficiaries, often at the suggestion of our member advisory committees. So one example is that our Centene National Disability Advisory Council suggested we create some information for consumers about their rights and responsibilities should they need to be hospitalized during the pandemic. Like many other plans and providers, we've certainly also increased our focus on telehealth or virtual care for all of our member populations, including dual eligibles. Michelle mentioned some of the challenges around access to devices and having enough minutes, having good wireless access, and we've absolutely experienced all of that. I'll add in one other barrier is that some telehealth platforms also are difficult to use when somebody needs an interpreter or has caregivers that want to participate in the conversation. So this is something that not all platforms can easily support. And then of course, having access to good contact information, email addresses are hard to find. So really, I think there's some opportunities there to help our dually eligible members both access the technology that they need and increase their literacy and their comfort with these different communication channels. And then I know I am short on time, so just very quickly, I'll mention we did work with Nickel to put out some videos and tip sheets for providers on delivering disability competent care during the pandemic. And also have certainly been busy with a number of different partner organizations. I mentioned some of the workforce partners and others to advocate for policy solutions that would better support duals in the community, and have been looking at flexibilities that have been granted and should be sustained for the long term. So I think we'll be able to talk about that a little bit more during the roundtable. So with that, I'll say thank you again for this opportunity, and I'm going to turn it over to Sue and Gretchen. Thank you.
Thank you so much. It's really quite really inspiring to hear about some of these interventions that plans are working on. We've heard so much of the negative news, and we've had so much of the kind of flat-footed panic where we had new situations emerging, and it's actually really refreshing to hear about plans and community in other states working together on these issues. And I do just want to echo a point that was made earlier that by having some of the demonstrations and the alignment in place ahead of time, we were really better positioned than we would have been. It's easy to focus on kind of what was discouraging or frightening about this, but it's also important to focus on the positive. And so in Minnesota, we have fully aligned Medicare, Medicaid programs, both for seniors and for adults with disabilities. And so we were in a good position there to help people because health plans are working with not just the healthcare needs, but also the functional needs on the long-term services and support side. And there were already good care coordination and case management relationships built. So that said, it did hit our nursing homes and our assisted living hard, as was noted previously. So one of the things the state was able to do was to get additional funding out, first to nursing facilities across the board, paying for PPE and additional staff, overtime pay, and other kind of costs associated initially. We also were able to get funding for extra payments to our assisted living facilities, and we relied heavily on our managed care partners there in terms of getting some of those funds out the door. We were also able to waive some of our requirements for in-person face-to-face assessment of functional need, so that care coordination, case management, and assessment could continue on, even though, as was noted, there really was a lot of restriction in terms of being able to see people face-to-face. We even had a provision where adult day was allowed to be provided remotely or in person as a one-on-one service. We made telemedicine easier across the board. I think as a state, we were kind of lagging behind, and there were a lot of concerns about misuse of telemedicine or what kinds of ability people had actually to get to telemedicine. And we saw pretty incredibly across the board that behavioral health in particular access was maintained because of the newer flexibilities in telemedicine. So I'm hoping that we do see some of that as ongoing improvements in our system as well. Another piece that we, of course, we're working on, as many states are, is uninterrupted healthcare coverage for people. So instead of the constant churn of people on and off of Medicaid due to the requirement to renew all of the paperwork associated with, confirming continued financial eligibility, we were able to lift that. And we've seen quite an increase both in our number of people enrolled in the program and a decrease in new applications, likely because a lot of the churn that was occurring previously is now not occurring. What we learned, though, also during that process was that as a large agency with many people working in different areas and suddenly all of us at home, that in some ways our long-term care programs and our managed care for seniors and people with disabilities is somewhat isolated. And so some of the initial consequences of decisions that were made quickly weren't apparent to people. So when we kind of locked eligibility in place, there was initially a process where we stopped changing people's basis of eligibility from the more generous adults without children to the elderly basis of eligibility when they became 65 or when things changed. And of course, our systems are all set up so that you can only enroll in our seniors managed care program if you are using an elderly basis of eligibility. You can't get into home and community-based services waivers unless you have the right criteria set out in your eligibility. So we've had to kind of work with a broader group of people than we do operationally to make sure that some of our people, as they were turning 65 or as they were becoming disabled, were able to make appropriate choices and get into the services that they are entitled to. So that's a little bit of kind of a state background here. And as Tom was discussing, we had a lot of recommendations for how to structure programs to make sure that we have the best kind of structure for people to fit into during this kind of time of crisis. One of the things that we really appreciated that we did have set up was the full alignment and the number of benefits and scope of benefits that we have in place inside our managed care program. So the fact that we have all of the managed long-term services support benefits in one contract, that we also have the behavioral health benefits in that same contract, so that one managed care organization can go ahead and manage folks. Another piece that we really appreciated was that both the healthcare kind of case management and the functional case management, so you know, the work with elderly labor or other services in the community was in the hands of one case manager. So as things kind of changed rapidly and people had to stay home quickly, there was more ability and flexibility to respond to the situation, and there were relationships in place. I think one of the things that we wish that we had gotten done before the pandemic hit was the data sharing regarding hospitalizations is not as robust as we wish that it had been. We're in the middle of creating a program where hospitals and nursing homes would report into a central location, and that information to be shared almost instantaneously. And that is not quite completed. We hadn't pulled our managed care organizations in, so I would say that was a loss in this process, but it certainly gives us a good case study in why we need to keep working on those efforts. You know, workforce does continue to be an issue. We do see the need to continue to collaborate between state and the managed care organizations to reach out to potential providers. There are people out there that are giving a lot of good support to people in the community and don't necessarily know how to bill for some of those services. And of course, we want them all to sign up and get paid for what they're actually doing. We also need use of the risk corridor, as Tom had mentioned, and directed payments to get funds out quickly to assisted living facilities. So that's a little bit of the kind of background in the state. And I'd like to ask my colleague, Sue Kavenger, to talk about how some of our health plans in Minnesota were able to use some of the flexibilities and respond during the pandemic.
Thanks, Gretchen, for that introduction and overview of how Minnesota responded. And as Gretchen said, I'm going to give some examples of some of the specific things that we work collaboratively with our health plans to implement things for our members during this crisis. I use the word collaboration, that is a key to the work that we've done in Minnesota for the last 25 years, is that we do have a collaborative spirit with our 7 MCOs that provide our special needs purchasing plans. And so I just want to note that you're not going to see me on camera. So if you're looking for me, don't be looking for that as well. As far as how we worked collaboratively with our health plans early on, we have a care coordination work group, and we also meet monthly with our health plans. But it was identified that we needed to meet much sooner and earlier, and so we set up weekly meetings that then just turned into bi-weekly meetings where we talked about communication strategies and different things that health plans could do to implement the strategies that the state was coming up with, and vice versa. You know, we've been talking about the use of supplemental benefits. It is one of the recommendations. In Minnesota, many of our plans do have a substantial list of supplemental benefits, but I want to make note that if you know Minnesota, we are primarily rural with one large urban area. And so our plans that are able to service our urban area have the money in the bid process to provide some really great supplemental benefits. And that is not necessarily the case with our plans that serve primarily rural areas. And we're unique in that we do have plans that serve almost all rural areas. So I'm not necessarily talking about this perspective from a uniform basis across all of our health plans. But those that did have those supplemental benefits found that it was an extremely important process. They were very important that they had those in place and made full use of those. And I've talked to health plans that said they were so very glad that they had those supplemental benefits, such as extra meals, extra services. One of our plans actually provide iPads in the past to their members, and so they were able to actually load COVID-specific information to members and on those iPads and get communication and information out. As a state, we've been worried about what about regular services and regular preventive services. Many of our health plans in the past have used in-home testing kits for colon cancer, A1C testing and such, and they've actually elevated the use of those tests during COVID and have been encouraging a much higher use of those services. Flu shots. We all know that we now need, and there's a renewed effort to get people to get their flu shots. People fearful of going out, or their normal way of getting the flu shot is no longer available. Our plans have all upped their game on getting communication out about flu shots, and we were real excited that as a demonstration state, CMS actually reached out to the state and to our health plans, and we were able to produce with CMS a postcard that will be going out under the state logo, but to each and every one of our MSHO health plans about the ability to, about reminders about getting a flu shot. And so our health plans all sent CMS their list of members, and they're going to be going out in different languages and such, and we're very excited about that. I know I'm getting short of time, but I do want to talk about caregiver support and some of the efforts our health plans have been using prior to COVID about really wanting to up the game of caregiver awareness and the services that are available under our programs. Our MCOs tag teamed with our AAAs to come up with an actual campaign that just in January and February of this year had introduced to the state. And of course, we know what happened. And just this morning, we were able to have a phone call again to renew that. And it's one of those things that it's like, if only we had been able to do this prior to COVID, I think we would be in a much better place. But it's a good example of learning from what we don't have and what we do need. And so our caregiver awareness, it's really lining up providers to get MA enrolled so the health plans can use them under our waiver services, making sure that providers and our care coordinators are connected to actually get that service into the hands of people who need it. And as I said, I'm just kind of in a finality. I'm looking at my computer, and some time ago, this is an actual horoscope that I had, and it actually resonated with me regarding the program that I've worked on in integrating care, which I always say integration is never done. I've been doing it for 25 years, but this was my horoscope, and I think it also is timely for what we're talking about today. It says, the work you've done will be obsolete one day, and then much later, it will be historical instead. So commit as though this is the most important moment. In many ways, it is. And so with that note, I will turn it over to our moderators. I think we're going to do some questions and answers. Thank you.
Thanks, Sue, and thanks, everybody. I'm going to welcome back Michelle, Laura, Sue, and Gretchen, and we're going to have a little bit of a roundtable here. And this is an important time, so I appreciate you sharing and ending on that note. So I'd like to start with an initial question that focuses on the policy recommendations, and you all identified, and thanks for sharing all the innovative work that you all are doing in terms of addressing this pandemic. But I want to start with the policy recommendations, and you saw the lists, and certainly everything you fed into that was very helpful and important in terms of forming those policy recommendations. But what are the most important one or two that you can think going forward, as if you were to talk to federal policymakers, state policymakers, and thinking it through about really fundamentally changing this? And Michelle, I'm going to start with you. You listed out 4 actually in your presentation, but I want to hear you expand on it a little bit from a policy recommendation perspective.
Certainly. Well, I think the first thing is the innovation programs and models. They're very important. It gives us real-time adaptability in a structure that is not used to being that agile. So I think that the program flexibilities are key, and the partnerships between CMS and the states that have just continue to become enhanced through these testing processes. The thing I would caution is that we do need to be mindful of an oversaturation and the unintended consequences of programs that we lose parity. It causes confusion, particularly healthcare is so hard to navigate anyway. It can really cause some beneficiary confusion. It can be difficult for providers. So I think at some point we need to not just continue to layer on, but we need to take a step back and say, what's most effective? And let's focus our energies in some of those places. The second thing is the states can do some really wonderful things with their contracts, particularly with their unaligned duals using the SMAC. I don't know who came up with that acronym, but with the former MEPA agreements, and to improve integration and to promote and remove barriers to enrollment in integrated care. I think that's really important. And some of the key things are those in lieu of benefits and flexibilities on a case-by-case basis are something that are really, really important. And the third thing would be we have to live outside our comfort zone. So one of the things, not only from the financial alignment demonstrations, but we operate a FIDE SNP in the state of Idaho, is educating and working with both CMS and the states about what are communication rules allowed? What does marketing really mean? Because Medicare and Medicaid operate fundamentally differently when it comes to the rules of engagement on those topics. And those are easy things that we can address now. So those would be my 3.
Right, great, thanks so much. And there's a lot of resources now that are out there for states that are thinking about this, right? You've got the Integrated Care Resource Center and the Duals Office, right? So if you go back even just a decade, those resources didn't exist for states to be thinking about this in a more meaningful way. So I think many of the policy areas you identified, and clearly part of going into this should be a simplification, right? We make everything in healthcare so complicated, and nothing is more complicated than what we expect duals to navigate on their own. And yet, I really think it's the opportunity to focus on simplification in terms of how we better serve that population through better policy. So Laura, I'm going to turn to you next. Same question. Sort of, if you were to look at 2 specific policy areas you'd want federal, state, plan people to focus on, what are the 2 that you think meaningfully can change sort of the trajectory of where we're at and how we can serve duals?
So the 2 I would pick, I would start on the first one you guys mentioned, increase alignment between Medicare and Medicaid. I mean, that is really the crux of it all, right? And I think like Molina, Centene also has been extremely active in investing in the dual demonstration program, and we've seen a lot of really great success around that program. And I think there's absolutely something there. And I appreciate that CMS has put out an open offer for additional states to join the demonstration program. I think it's not an easy lift to get it off the ground for states or CMS or the health plans as well. But I think, to the extent that states can get over that hump and put something like that in place, I think it has a lot of benefit. And by the way, during this budgetary season that we're in, I think could be a good opportunity for Medicare and Medicaid to actually share effectively in savings in a way that they can't under other models. The second policy lever that I would choose, to the extent that not all states are set up to kind of go all the way up the integration scale, is really around data sharing platforms. So I think there is a lot of challenges there around being able to coordinate care for duals when, you know, the Medicaid entity doesn't have insight into some of the things that are happening on the medical side of the house. And I think, you know, that's certainly a place where there have been certainly some investments, and the 2021 DSNP integration requirements have some additional investments that I think will help to build up more of that infrastructure. And I think there's a need for continued investment in that realm.
Yeah, I agree on the data piece completely. And I think, you know, two things. One, I think every state should have an alignment strategy. Whether you're a fee-for-service or managed care, every state should have some strategy on what you're doing around duals to try and create better alignment within your state. And it's hard work, right? And you've got to have resources dedicated specifically for that strategy. And then on the data side, I think we heard that over and over again in all of our conversations around the limitations of data and what it meant in better serving, but when the data was available, how meaningful that was in changing outcomes for dual eligible members. And what I don't want to see happen is, well, the MIPA requirements are helpful and the statutory requirements, just don't make it a check the box exercise. Actually think through how that data can be actionable at the state level and for the plans in terms of sharing that information and acting on that information. Same question for you, Gretchen and Sue. Sort of what would be your top 1 or 2 policy recommendations, either from the list that we shared, or, you know, if you think of something beyond that list in terms of how do we take the lessons learned from COVID and serving one of the most complex, frail populations out there and improve outcomes for that population?
Mm-hmm. So this is Gretchen. You know, I think I'm going to borrow some of the points just made about, you know, the more alignment, the better. The more that we can have people who are both committed to and aware of both the functional needs of people, the community needs of people, and their healthcare needs, the better off the care coordination can be. And especially with a disease like COVID, we need to be on top of things for people. So I think that the fact that we have care coordinators that are both invested in our people getting the meals they need, our people, our caregivers getting to the house, and who also are aware of what are the chronic conditions this member is facing, how do we keep them safely at home. I think it's really important to have that support for people. This is definitely going to be a very challenging budget period coming up for states. I wish that we could look at some new and shiny financial alignment initiatives with CMS so that states could see more concretely some of the value of investing in people, looking at people as a whole person, and both their Medicare-funded healthcare and their Medicaid-funded healthcare in one package really is going to result in better outcomes. It's going to result in people avoiding nursing facilities longer. And if states could share in some of that Medicare savings, and even vice versa, I think that we would have a lot more in this particular time frame buy-in and understanding of why these programs are important. So I hope that we don't lose our alignment during this time frame, because people are going to get pretty focused on the bottom line here pretty quickly, and that we can continue to help people understand how much further we can get by treating the whole person and aligning both their Medicare and Medicaid benefits and needs.
Yeah, well said. I mean, I think people oftentimes forget that when you look at the results of some of the third-party evaluations that are out there, and Minnesota is a great example of it, right? Where are the savings? The savings are in inpatient admissions and readmissions. And where are their higher costs on home and community-based services, which is exactly what we want to see happen, but it's higher costs for states and all the savings accrue to the federal government. So as part of that policy dialogue of how we build alignment, one of the things that I thought was critical about the demonstrations where it gave states the opportunity to actually share in some of the savings, and the results have shown that's exactly the way it plays out when we're able to improve outcomes and change the trajectory. So thanks for raising that point. Sue, did you want to offer up the top one or two policy areas?
I've worked with Gretchen for so long. I just concur with what she has said, but I just wanted to build on even what you said. Minnesota's been doing this for a long time, but when things like this happen, I always say integration is never done, and it's constantly evolving, and it really comes back down to that individual member of who you're serving and what it is they need. And when you look at what is it the member needs, and you ask questions, I always say, how would it look like to the member? And that's what we need to keep remembering in all of this. It's very complex, is that we do need to keep thinking of that member and what it is they need, and how can we create programs and around that to make sure that stays intact.
Well, and I think one of the things that's so important to remember is, when we talk about dual eligibles, it's not a homogeneous population, right? I mean, we've barely touched on the IDD population and their unique needs, and individuals with serious mental illness, as well as their unique needs. And so thinking about solutions as it relates to building alignment and then creating the right service structure around that is so important. So I'm going to move on to the next question then. So we'll stick with alignment, and I'm going to go to our two plan representatives. I'll start with you, Laura, then go to you, Michelle. For plans where you're aligned in markets, and either through the demo or through a DSNP, how has that helped? Give me one or two concrete examples, and we've heard some of them over the course, but specifically as it relates to this, just really lay it out for our listeners. How does alignment help in terms of where you're able to get that established?
Yeah, so I would just say I recently just learned of this great success story from our Superior Health Plan MMP program in Texas that I thought was a great example. I mean, as you know, there's so much anxiety right now about accessing care and when to go to the emergency room and how to get access to your PCP. And so we had a service coordinator who called a member just for a routine reminder, and found that member to be very distressed and in a lot of pain in one of their eyes, and very frustrated that they weren't able to get into their PCP and they didn't know what to do and where to go for additional help. And so they were able to intervene, get that person in with the doctor same day, arrange the transportation that was needed to get them in that day. And then they were able to go from there to an ophthalmologist and get treated. And so, really, I think it's having all of those different levers in one place right now in a time where, the systems are breaking down. They're even more difficult to navigate than ever before. I think it's very critical.
I think sometimes we get caught up in sort of healthcare policy jargon and we forget the real life implications of this, and being able to provide a concrete example like that is so helpful. So Michelle, same question to you.
I would say it's the whole person perspective. And with that, the good things follow. The good things meaning higher quality care, reduced costs, and it also provides the ability to use the healthcare dollars in the most effective way possible. So I think those are two big things. And then I want to point out, I don't want to focus on the cost side because it really is about the individual, not only the cost savings, but the cost avoidance, while quality scores just keep climbing and climbing and climbing. And it's not just a statistics on a HEDIS score or, what services did you get? It's about the customer satisfaction, feeling independent. It's about people having stability in their functional levels, and actually in some cases improving, which keeps them in an independent setting for longer, which is typically people's choice. So I think those are all the really critical things that are easier to do in the demonstrations or any integrated program where you have full accountability for the outcomes of an individual. It puts the person in the center easily. without barriers of structure. And I want to just comment on a point you made earlier about the integration programs and the ability to share savings with the state and how important that is. Sometimes I think we lose sight of when there are integrated programs and the savings accrues to Medicare, but now we're seeing states also saving. When Medicaid costs go up, federal funds are the majority part of these dually eligible Medicaid funding. So this is cost control and better outcomes is a federal and a state opportunity. And that's why I think it's really important that we have more and more opportunity to share the good outcomes, financial and otherwise, across both federal and state programs.
Yeah, thanks for pointing that out, Michelle. So Gretchen and Sue, a slightly different version of the question around the importance of alignment. So if you think through what you've through the last several months, how has your response to COVID been supported in terms of those plans where you see alignment versus where members don't have alignment and are fragmented?
Gretchen, did you want me to take that one first?
She's nodding her head yes, Sue. First of all, on our senior programs, is that, for the most part, our duals are in our MSHO and our integrated program. But we do have a Medicaid-only program for seniors that is unaligned. Although we have the benefit of our health plans kind of moving some of that, the provisions that they do for our integration to the care coordination of that. But I do believe it is kind of some of the things that I talked about is those supplemental benefits. It's those flexibilities of being able to move the money back and forth, and use the money in a different way that I have seen. That it does differ. Health plans aren't necessarily going to come to us and say, oh, we didn't do this for our Medicaid only. But I do know that that is the case, is that, that those flexibilities, particularly with the supplemental benefits and the coordination of the care across the settings, getting people in for those preventive services because they're paying for them, those kinds of things really, it really does make a difference. Yeah, thanks. And that's, I think, one of the advantages that, managed care has as your platform, as you think about it, is to be able to innovate some in terms of how you use some of the flexibility around those funds versus, a traditional fee-for-service model. So being able to see that, we think about the care coordination piece oftentimes around this. We sometimes don't focus enough on the flexibility in terms of, Michelle, you mentioned the whole person, right? But really identifying all the needs, particularly during these very challenging times of a pandemic. So I want to thank all of you again for your time and sharing all the great work that you're doing on the ground during these very challenging times. And again, I think we need to continue to elevate this debate and discussion around how do we better serve dual eligible members going forward and learn from all the lessons that we have here, build on the work that's already been done to date, but then not rest on that and continue to advance and have a robust policy discussion around what really makes sense going forward to better serve that population. And thanks for all your insight today in doing that. So Michelle, I'm going to turn it back to you to close it out for us.
Great. Thank you so much, Tom. And thanks as well to all of the fantastic speakers that we had today. I learned a lot. I'm sure everyone else did too. And I just want to echo Tom's comments on the importance of continuing these conversations now more than ever. So that wraps up our webinar for today. Participants will receive an evaluation after you leave the webinar, and we ask that everyone please fill it out. It's very helpful to us. The webinar slides and recording will be posted on chcs.org. So please, you'll get an email about with the link, and please feel free to visit and listen again anytime. We will be releasing a paper in the next several weeks that covers a lot of this information, as well as includes some additional information. So please look out for that. And lastly, I just wanted to thank Arnold Ventures again for your support of this important work. Thank you all for joining.